Hello everyone, this is Dr. Usman Babar, resident psychiatrist, and today we will be discussing history taking in psychiatry. Like any other field, taking patient's history is very important to understand what the patient is going through and formulate a diagnosis so that appropriate treatment can be started. So, what is psychiatric history? Psychiatric history is a structured and comprehensive account of a patient's past and present mental health status gathered through clinical interviews and collateral information. It includes details about psychiatric symptoms, past diagnoses, treatment, personal and family history, substance abuse history, medical conditions, psychosocial factors. The psychiatric history helps in understanding the patient's mental state, diagnosing psychiatric disorders, and formulating an appropriate management plan for the patient. These are the general parts of a psychiatric history. You may find one or two additional points in different histories from different consultants, but more or less, this is the general format. It covers almost all the parts that you will need for an appropriate history from your patient. First of all, we have the biodata, followed by the chief complaints, then going through the history of presenting illness, past psychiatric, medical and surgical history, personal and family history, pre-morbid personality, important negatives or what we call negative history, general physical examination, relevant neurological examination, mental status exam, and finally our diagnosis. Now, we will be discussing each and every one in detail. First of all, let's start with the biodata. So as the name indicates, it consists of the patient's name, their age, their cultural background, as it will help us to understand where the patient comes from, what language does he or she speak, and how can we take an appropriate history and communicate with the patient. Followed by the patient's residency, marital status, occupation. Referral source is very important. Either the patient was referred from an OPD or an emergency setting or from another consultation. Then is the reason for admission, that is brief summary of presenting complaint and need for admission, but this is also discussed in its separate heading called the chief complaints. So, the chief complaints in psychiatry refer to the main symptoms or concerns that bring a patient to seek psychiatric evaluation or treatment. These are usually reported in the patient's own words and provide the starting point for clinical assessment, but are often written non-verbatim to save time and when the complaints are common and straightforward. The chief complaints are followed by history of presenting illness, in which we elaborate the patient's symptoms. First of all, we start by stating when the patient was last well and how did the symptoms start, whether they were sudden or gradual, followed by any preceding events in the form of triggers, stressors, or medical issues. Then we mention the duration and course of the symptoms, either they were continuous, episodic, or progressive. Then we ask for the precipitating and exacerbating factors which may decrease or increase the patient's symptoms. Finally, we mention the impact on the patient's personal, social, occupational, and academic life. Then we mention the symptoms which are associated with these core symptoms. These can be psychiatric or medical. And finally, any treatment that the patient has taken, whether prescribed or over the counter. We also may ask the patient any response that he showed to the treatment. After HOPI, we move towards past psychiatric history. In this, we ask the patient about any past psychiatric condition or symptom that he may or she may have had faced in their life. We ask about the onset and initial symptoms, any mood episodes that were present. We ask about the course of the illness and the pre-morbid functioning, that is, did the patient return to baseline between episodes? Finally, there are some questions about the treatment which we need to ask. We need to ask about psychiatric medication, what was the type, whether it was injectable or oral, were there any side effects, what was the overall response to the medication, and was there any adherence to it or not. We may also ask about any psychiatric admission that the patient had, the number of admissions, their duration and reasons. Along with that, any non-medical approach towards the patient's symptoms, which could be in the form of electroconvulsive therapy, RTMS, etc. And any warning signs that we may want to see in these patients when we start the medications. For example, any history of neuroleptic malignant syndrome, etc. Then we go forward with briefly touching the medical and surgical history. We ask about any medical conditions, previous surgeries, hospitalizations, any continuing medical condition for which the patient is still taking medications. Personal history is something that we need to assess in very detail, because events that occur in childhood can often have their effects in their adult life and can present in the form of diseases. So, for this, we need relatives of the patients who can give a detailed account of their developmental and early childhood history, especially the patient's parents or elder siblings. First of all, we ask about the patient's developmental history, the patient's prenatal, birth, and postnatal history, and any developmental milestones that were delayed or were abnormal. Followed by the patient's childhood, any early separation, emotional abuse, trauma, or medical illnesses that may have impacted the patient as a child. Followed by patient's schooling, their level of education, their academic performance, their friendships and social interactions, and any history of bullying. We move on with occupation and work history, the patient's type of job, performance and stability, and the patient's relationships and sexual history. This is a sensitive topic, so must be assessed carefully. We ask about the patient's significant relationships, marital history, and children. Then we move on towards the legal and forensic history. Any past criminal or legal issues, anytime the patient was held in custody, what was the reason, and whether the patient was proven guilty or not. Then patient's substance use history, the type, frequency, duration, dependence and withdrawal symptoms, and finally the patient's social history, the living arrangements, number of rooms, household members, social support system. We also ask about whether the patient is in a joint or a nuclear family, who is the decision maker in the home, who is the breadwinner, etc. etc. Then we move towards the family history. In this, we ask about the patient's parents, whether they are alive or deceased, what's their age, if they are deceased, what was the cause of their death. Similarly, we ask the same questions regarding the patient's siblings, and we ask about the patient's family relationships, their quality of bonds, any conflicts and support system, and any family history of psychiatric and medical disorders if present. The premorbid personality refers to an individual's characteristic patterns of behavior, temperament, and interpersonal functioning that were evident before the onset of the psychiatric or any neurological disorder. It serves as a baseline for comparison to identify changes associated with the illness. In this, we dig out the character traits. Either the patient was friendly, reserved, socially withdrawn, any attitudes towards religion, health, personal well being. What was the predominant mood? Either the patient was anxious, stable, dysthymic, etc. Then we ask about the patient's leisure activities and interests, any long term relationships and attachments, and any fantasy life and coping mechanisms. After that, there is a list of some important negatives that should be there at the back of your mind and you should exclude them. This is also called negative history. This includes any persistent sadness, anhedonia, worthlessness, elevated mood, excessive persistent worrying or panic attacks, hallucinations, delusions, thought disorder, memory loss, disorientation, drug history, social isolation, suicidal thoughts and plans, homicidal ideation, thoughts, and aggressive behavior, chronic interpersonal difficulties, any compulsions, history of seizures, head trauma, stroke, thyroid dysfunction, any history of fever, infection, or encephalitis. Then comes the general physical examination, or GPE for short. Now, I won't get into the details of the general physical examination, as that is something I assume you already know as a medical doctor, but here we will touch its importance in psychiatry. So, GPE in psychiatry detects medical conditions presenting with psychiatric symptoms like hypothyroidism, delirium, stroke, identifies side effects of psychotropic medications like extrapyramidal symptoms, and assists in medication safety. So, a thorough GPE ensures a holistic assessment of the patient and prevents misdiagnosis of medical illnesses as psychiatric disorders. Same is the case with relevant neurological examination. You don't need to go into a detailed neurological exam, but a focused neurological exam is needed that helps differentiate psychiatric disorders from organic conditions and detects medication side effects. The clinical importance is that It can detect organic causes like stroke, epilepsy, dementia to the patient's psychiatric symptoms. It can identify medication side effects and assist in diagnosing functional neurological disorders. The key components are that you have to check for the cranial nerve damages, the motor system in respect of tremors, rigidity, involuntary movements, which we call tardive dyskinesia. You have to check the reflexes, coordination, gait, sensory exam, and that's it. You don't need to go into a detailed neurological examination. If needed, you may have to go for a liaison with a neurological unit in your hospital. The mental status examination is a structured assessment of patients' cognitive, emotional, and behavioral functioning at the time of evaluation. It helps in diagnosing psychiatric disorders, assessing risk factors, guiding treatment, and differentiating psychiatric versus organic disorders. The components of a mental state examination are appearance and behavior, patient speech, mood and affect, thought process, thought content, perception, cognition, insight, and judgment. A detailed video would be made about the mental status examination as it holds a very important place in a psychiatric history, so we don't need to go into detail now. Next, we come to the final part, that is the diagnosis. A definitive psychiatric diagnosis is based on a comprehensive medical assessment including history and MSc, collateral information, and sometimes investigations. It has to align with standardized criteria such as DSM-5 or ICD-11. Examples are schizophrenia, major depressive disorder, generalized anxiety disorder, etc. Sometimes, however, the information we get is not sufficient to go for a definitive diagnosis. Thus, we make a provisional diagnosis, which is a tentative diagnosis based on insufficient information or ongoing evaluation. It is based on initial clinical impressions and may change as more data emerges. It is also used when waiting further history, investigations, or symptom evolution. Examples are provisional diagnosis can be major depressive disorder versus adjustment disorder. In psychiatric history, identifying the source of information is very crucial because it affects the reliability and validity of our information. It helps to assess any biases or potential distortions. It guides clinical interpretation as self reports may differ from collateral accounts, and it supports a more comprehensive diagnostic formulation by integrating multiple perspectives. So, at the start of each history, we do need to mention who was the provider of the history. Either it was the patient himself or herself or any relative, and if there was a relative, then what was the relation of the relative to the patient? Was it a sibling or a parent or just a friend? So that was all about a detailed psychiatric history. Topics like mental status examination require their own video in detail, and that will be made shortly. Thank you for watching it. Like and subscribe.